Hello? 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 Am I audible? Hello?
Yes, sir. Hello. Yes.
Okay, great. So today we are going to continue our lecture on MSK. As you guys know that we did, a lot of nervous supply. We did upper limb, we did lower limb. The topic which we are going to discuss today is going to be radiculopathy. It's really important, and you are going to have a lot of MCQs in your on your due word as well as on your real exam as well from radiculopathy, right? So what is radiculopathy? Let me just, can you guys just see my screen? Hello?
Yes. Yes.
Okay, perfect. So one thing which you should just keep in mind that we have some spinal nerves, right? The spinal nerves basically exit a foramen which is known as spinal canal. That's called as spinal canal. So the spinal nerves move out through spinal canal. What is radiculopathy? Whenever this spinal canal either becomes stenosed or whenever it become, like thickened and the lumen size become thin, it would start compressing your spinal nerve. That's simply called radiculopathy. Okay, is it clear? That's radiculopathy, right? So there are some features of radiculopathy which we are going to discuss, and what can lead to radiculopathy as well. We are going to discuss that, right? So radiculopathy basically is compression of the nerve root at spine. Whenever your nerve root is getting compressed at the level of spine, that's called radiculopathy, right? So we have lumbar radiculopathy. For example, in your lumbar vertebra, whenever the spinal nerves are getting compressed, that's called as lumbar radiculopathy, right? So what are the causes of radiculopathy? That's really important. It can be due to herniated disc. It can be due to something called spondylolisthesis, okay, or it can be due to spinal stenosis. So what is herniated disc, right? You guys know that between every of your vertebra, you have a pad, a fibrous pad which is present within every vertebra, right? That's basically also known as vertebral disc, right? Sometimes this disc can, okay, so we have, some ligaments which are present around this disc. Sometimes due to like weight bearing activities or due to like someone is lifting a lot of weight, sometimes they can, this disc can herniate backward to a ligament which we'll be discussing. That's really important to know. And it can just move into that canal and it would start compressing your spinal nerve, right? And that's simply radiculopathy. Because we discussed, whenever we are impinging, compressing, or compromising your spinal nerve, that's called radiculopathy, right? So let's just go to our next slide. You guys can see that the intervertebral discs are basically, a cushion between vertebrae, right? So they're basically going to act as a shock absorber, right? These are the pads which are present between your vertebrae, right? Cushions used for shock absorption, right? Okay.
Mm, uh, Hello, we cannot hear you clearly.
Hello.
No, we can hear you clearly, actually. I think it's your Wi-Fi.
Hello. Can you guys?
Yes, we can
Yes,
hear
we
you.
can see it clearly.
Okay. Okay. That's great, right? So we have, okay. So if we just zoom in the structure of the vertebral disc, it have certain components, right? One is your nucleus pulposus, right? So you can see this is your nucleus pulposus, which is surrounded by annular fibrosis. If you guys remembered from your embryology, we discussed three layers, right? The ectoderm, the mesoderm, and the endoderm. Did you guys remember that? Hello?
Yes.
We discussed that the mesoderm is then going to transform to a structure called notochord, right? The notochord is going to send signals to the ectoderm, and the ectoderm then is going to transform into neural plate. Remember?
Yes.
Right? So the notochord, the remnant of notochord is your nucleus pulposus. That's really important. The remnant of notochord in a mature individual is your nucleus pulposus, right? Which is the central component of this intervertebral disc. So you can see herniated disc. How does the disc herniate? So it's the most common cause of radiculopathy. We know that, and it's seen whenever we have degeneration of annulus fibrosis. So you can see it here. So we have this ligament called posterior longitudinal ligament, right? I'm going to show it in the next picture really clearly. So sometimes due to weight bearing activities, we can have degeneration of annular fibrosis, and as the annular fibrosis become degenerated, so the nucleus pulposus can be pushed backward into the spinal canal piercing your posterior longitudinal ligament. Posterior longitudinal ligament is really, it's really delicate structure, right? So it can easily rupture, and nucleus pulposus can bulge into that spinal canal in which your nerve is, coming out, which can lead to radiculopathy, right? So here you guys can see that in the picture. Okay, so the herniated disc, it's most often you're going to herniate posteriorly, right? So this is your posterior longitudinal ligament. It's really thin in nature, it's really delicate, right? So due to compression, due to weight bearing activities, what happens, we can have degeneration of that annulus fibrosis, and nucleus pulposus would move backward, and as it moves backwards, it's herniate into the spinal canal. It would compress the nerve, which is radiculopathy, right? So we have posterior longitudinal ligament. It's really thin, it's really delicate, right? The weaker structure as compared to the anterior longitudinal ligament, right? Is it clear? Okay. The next thing is spondylolisthesis, right? So what is spondylolisthesis? It's really simple, right? For example, these are your vertebral discs, right? Okay, this is your disc, and these are your vertebrae, right? Sometimes this disc can slip over one another, right? For example, if this slips over one another, what would happen as a result of that? If this vertebra is moving forward and it's moving backward, right? Again, we can have, and this is your spinal canal. Due to the movement of this rib posteriorly, again, the lumen of the spinal canal is going to become thin, and it can start compressing your spinal nerve, leading to radiculopathy, right? So the forward displacement of one vertebra over the other, right? If this displaces, in the forward direction, it's going to move backward. It's going to compromise your spinal canal, which is going to again lead to radiculopathy. So spondylos stands for the vertebra or spine. Listhesis is movement, right? Okay, so the spondylolisthesis again is going to lead to degeneration of spinal cord as well, because we know that spinal cords also run in this fashion. Okay, so it may cause radiculopathy. Okay, spinal stenosis, it's really important. So here you guys can see we have a ligament called as ligamentum flavum, right? This is going to be one of your U-word MCQ as well, right? Okay, so for example, if the ligamentum flavum become hypertrophied, right? If it's becoming hypertrophied, it means that again the lumen size of the spinal canal would decrease. Am I right? Decrease lumen. Am I right? Hello?
Yes.
Yes.
Ligamentum flavum is getting hypertrophied. Can it lead to radiculopathy?
Yes.
Okay, perfect. Would again lead to radiculopathy, right? And how are we going to assess the radiculopathy? That's really simple. When an individual is, flexing forward, right? If an individual is flexing forward, always when an individual is flexing forward, the lumen size normally increases. The lumen size normally increases when, individual flexes forward, right? And as an individual, extend backward, the lumen size normally decreases, right? So for example, if an individual is having ligamentum flavum hypertrophy, right? And as he flexes forward, so the pain which is due to this radiculopathy is going to improve. Does that make sense? Because, it's already being hypertrophied, and as we are flexing forward, we are making the lumen size big. So in that way, we will be releasing the stress on the nerve. Am I right? Hello?
Yes, the
Yes.
ligamentum flavum
Yes.
stretches and it takes like less space, so that's why the lumen will be.
Yes, it would stretch. It would just take less space, and in that way, the compression on the nerve, on the spinal nerve, is going to be improved, and the pain which is due to this compression is going to improve. So, in order to assess whether an individual is having radiculopathy or whether it's any kind of other pain, so you are going to tell an individual to flex forward. If he flex forward, the pain is improved. It's going to be confirmed that yes, it's due to spinal stenosis, which is ligamentum flavum, hypertrophy, right? Okay, so you can see it here. Spinal stenosis is basically due to narrowing of the spinal canal. How? It's basically age-related. With age-related, first of all, what happens? The intervertebral disc becomes shrink, right? So, for example, if this is your, vertebrae, your intervertebral disc becoming shrink, it's the size is becoming decreased. Obviously, with that, the spinal canal size is also going to decrease, right? And along with that, ligamentum flavum, if it get hypertrophy. So basically, the main goal of with aging is that we are decreasing the size of spinal canal. If you are decreasing the lumen or size of spinal canal, it's going to compromise the spinal nerve, giving you radiculopathy, right? So straight standing or extending backward is going to make the lumen more thin. It's going to worsen the pain in case of spinal stenosis, right? So spinal stenosis, you can see it here. This is your ligamentum flavum if it gets hypertrophied, right? We have something called neurogenic claudication. Do you guys know what is neurogenic claudication? We already discussed it. Yes. Okay. What is claudication? We discussed that concept if you guys remember. Hello.
Someone feels like numbness
Yeah.
and tingling after walking or pain in the legs
Physical activity.
after
And
Especially,
walking
I
for
guess,
a distance.
on exercise.
Okay.
there,
Perfect.
the blood supply compromised most of the time.
Perfect. Perfect. So if you guys remember, we discussed a condition that was, something related to your heart. What was that? Something steel was coming in the name. Yes, I want you guys to remember that.
Subclavian history.
Perfect. Subclavian steel syndrome. We discussed in subclavian steel syndrome. These were your subclavian arteries. These were your vertebral arteries. They were joining with one another at cerebellopontine junction. Okay. So what happened that before, you know, here sometimes you can have narrowing of the artery, right? Before before your vertebral artery arises, we can sometimes have stenosis or any kind of the lumen size is going to decrease. And we discussed as a result of that, the blood was reversing back. That was your subclavian steel syndrome. Did you guys remember? Vertebro-basilar insufficiency and everything was seen. You were seeing that?
Yes.
Hello? Okay, perfect. So as you can see, we were also discussing that individual, if he's using his left arm a lot, it's going to lead to ischemic pain. That was claudication, right? Why? Because we know that the blood supply to the hand is already compromised. So the blood supply due to stenosis of your subclavian artery to your hand is already compromised. And if you are using the hand, it means we're increasing the blood demand to the hand. So it's going to lead to demand and supply mismatch. And whenever we have demand and supply mismatch, we are going to be having ischemic pain, right? Hello?
Yes.
That was basically your claudication, right? So this spinal stenosis can sometimes mimics claudication of your lower leg, right? Sometimes, for example, if the blood supply is to the lower legs are compromised, it can lead to claudication once we are using a lot. If someone is running, it can lead to. Okay, did you guys remember something Leriche syndrome?
Yes.
Yes.
Yes, it's the occlusion or atherosclerotic occlusion of the external
External.
carotid or lower abdominal. It's called trophic changes in the legs, also impotency, and also compromise the blood supply to the lower limbs.
So were we seeing claudication?
Yes.
Is
Yeah.
external iliac.
Yes, external iliac become, due to atherosclerosis, the blood supply to the leg was really compromised. And if this individual with the Leriche syndrome was running, he was experiencing pain. That was an ischemic pain, right? So how to differentiate whether the pain is due to spinal stenosis or whether it's due to vascular claudication? So in order to distinguish that, I already told you. If an individual is flexing forward and the pain is improving, it means we are just increasing the size of your spinal canal. Am I right?
Yes.
Okay. If during flexing forward, the pain is improving, it means it was spinal stenosis, not claudication, not vascular claudication, right? So in this way, you are going to assess whether individual is having a neurogenic claudication or if he's having vascular claudication. Is it clear?
So can you please repeat?
Okay. As we discussed that we can have, pain in the leg. Let's suppose in this case, it's leg. It can be due to vascular compromise or it can be due to neurogenic problems, right? For example, if you have spinal stenosis, radiculopathy, right? How to differentiate both of them? It's really easy. Okay. You're going to tell an individual to flex forward. And as an individual flex forward and the pain relieves, what do you think what's happening?
Spinal stenosis.
Spinal stenosis. Yes.
Spinal stenosis. And okay, and if this individual is extending backward, the pain is worsening, then what do you guys suggest?
Also spinal stenosis.
Also spinal stenosis. But with flexing forward, the pain isn't improving and the pain is worsening with activity. What do you guys suggest?
Claudication.
That's the vascular claudication, right?
Vascular claudication.
So you are going to differentiate vascular claudication from neurogenic claudication. Is it clear? Okay. Hello.
Yes,
Yes.
sir.
Okay, perfect. So the next topic which we are going to discuss is sciatic nerve. If you guys remember, we discussed the branches of sciatic nerve just below or just at the level of popliteal fossa, just below. Can anyone just give me a brief overview of that? The muscle supply, what are the function of those muscles? What are the branches of sciatic nerve? Yes.
Below the popliteal fossa, the sciatic nerve divided in two branches. One is continuity of the sciatic nerve is called as tibial nerve, and one is go to the lateral aspect, very near to the head of the fibula. It's called as a fibular or a peroneal, common peroneal nerve, which further divided into superficial peroneal and deep peroneal. Superficial peroneal nerve is the sensory nerve. It gives supply to the anterior of the leg and the foot, the dorsal side,
I
and
think
the
still supplies to the lateral compartment.
Lateral compartment. Yeah.
lateral. Yes. Sorry, lateral compartment and dorsal of the foot.
Okay.
The
And
deep peroneal
function of lateral compartment muscles?
lateral compartment muscle is
Eversion.
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 Okay, perfect. What was
Eversion of the foot. And the deep peroneal nerve it's by the anterior compartment of the leg and giving sensory to the first and second web of the toe, means between first toe and the first finger of the foot, there is a web only. The small area there will be the sensory supply. And if we go the continuity of the sciatic is the tibial nerve giving muscles of the posterior leg, and in the foot is divided into the two lateral and medial plantar nerve. Give the sensory means sensation to the sensory innervation to the plantar side of the foot,
okay?
and it's also cause the flexion, I think, of the foot.
That was plantar flexion, right?
Plantar flexion, yes.
And dorsiflexion for the deep, which is supplying the anterior compartment. Am I right?
Yes.
Okay, perfect. If we have problem with common peroneal, we are going to see which drop, foot drop. Why?
Definitely is paralyzed the common peroneal, paralyze the both the anterior and lateral compartment of the foot, and it's also function as the extensor of the foot.
There is no dorsiflexion.
There is no
There's no dorsiflexion, yeah. There's
and
unopposed. Yes.
dominate, which is going to appear as foot drop.
Yes. And
Right.
most the site of the injury is the head of the fibula.
Yes, at the head of fibula, right? Common fibular clasp, that is head of fibula, right? Or during leg cast, it can compromise if someone is having any kind of leg cast due to fractures, it can compromise, right? So I just told you we are gonna discuss the upper part of the sciatic nerve here in radiculopathy. So this is where we are going to discuss the upper part, right? So we know that sciatic nerve is the largest one having that's 2 centimeter wide. And how does the sciatic nerve get compromised? Really important. Whenever we are having posterior dislocation of your femur,
Hip. Yes.
posterior dislocation of femur, really important, one of your word MCQ, right? So whenever it gets posteriorly or dislocate, sciatic nerve is going to be compromised. So in the upper leg, it's going to supply the posterior compartment muscles of your upper leg. What are the function of these posterior compartment of the upper leg? Extension
Extension of the leg.
Yes, hamstrings.
Flexion, length, leg,
and
and extending hip.
and flexion at your knee joint, right?
Hmm.
Okay, perfect, right? So you can see that they have lateral skin and everything. That was basically the common peroneal. Okay, so you can see the muscles of posterior thigh. We have the hamstring muscles and adductor magnus. So we have adductor magnus. A little portion of adductor magnus is also known as hamstring portion, right? So that little portion which is acting as a hamstring muscle that is which is going to lead to extension at the hip joint and flexion at the knee joint is also going to be supplied by sciatic nerve, right? Because that part is going to be acting as your hamstring of adductor longus, right? Okay, adductor muscles were supplied by which nerve? Latin word closing.
Obturator.
Obturator, yeah.
Obturator.
Perfect.
Obturator.
These are your hamstring muscles. We have three posterior thigh muscles: the semimembranosus, semitendinosus, bicep femoris. Okay, adductor magnus. I just told you that some portion of adductor magnus is also going to act as hamstring, right? Function is going to be same as that of hamstring. That's why it's going to be supplied by sciatic nerve, right? So the adductor magnus, the medial thigh is going to be present. It have two portion. The hamstring portion, you can see, like here we have the hamstring portion, right? Which is going to lead to knee flexion, hip extension, and hip rotation. Okay. Okay. What is sciatica? Do you guys know what is sciatica?
It's a compression of the sciatic nerve.
Compression of
The
sciatic.
radiating pain to the that side of the leg.
Okay, perfect. So whenever we have compression of sciatic nerve, right, it would lead to something called sciatica, right? So we are going to be having a lot of pain. That's basically a lumbar radiculopathy, right? Sciatic nerve basically exists at the lumbar level, right? It's going to again give us a pain, but this pain is going to radiate along the sciatic nerve as sciatic nerve is moving downward to the lower back, buttocks, and back of thigh. So this pain is going to move along the course of your sciatic nerve, right? How can we have this lumbar radiculopathy? We can have due to herniated disc, as we discussed. It can lead to compression, right? It can be due to inflammation. Okay, it's going to lead to inflammation, pain, and numbness in the affected area, right? So that's simply a radiculopathy, right? So we discussed that sciatic neuropathy it is going to be due to hip fracture or dislocation. Which dislocation? Posterior dislocation, right? Any kind of hip replacement surgery or prolonged compression, for example, coma or bed rest, it can also compromise your sciatic nerve, right? So as a result of that, if sciatic nerve is compromised, what are we going to see in an individual? We are going to be having hamstring muscle weakness. We know that loss of dorsiflexion, foot drop, the common peroneal is affected. We discussed that, and sensory loss as well, to the areas where it supplies, right? Okay, so radiculopathy syndrome. Okay, nerve root L5. So there are a lot of, it's a big nerve. So it have a lot of nerve roots, right? Okay, it's really important to know. Whenever we have lumbar radiculopathy and it compromises the nerve root L5, what are we going to see there? We are going to see weak foot dorsiflexion and toe extension. So what do you suggest? Whenever the L5 is compromised, which portion of your sciatic or which branch of your sciatic nerve is going to be affected more?
Common fibular.
If an individual cannot dorsiflex, which
Common peroneal now.
Common
No.
peroneal fibula.
Cannot dorsiflex.
Yes,
Dorsiflex is
Yeah.
deep peroneal nerve.
Yeah.
common peroneal nerve is
Common.
going to compromise more, right? So it's
Yeah.
really important. If radiculopathy is at the level of L4 or L5 vertebrae, that is affecting your L5 nerve root, because sciatic nerve is a big nerve, right? It have a lot of nerve roots, right? Okay, so most probably the common peroneal component of your sciatic nerve is going to be compromised. Individual with compression at L4, L5 is going to have weak foot dorsiflexion, right? Right? So it's difficult to walk on heels, right? Because if we are just walking on heel, for that we have to dorsiflex our foot, right? Okay. Hello.
Yes, sir.
Okay, if the radiculopathy is at the level of L5 and S1, and the S1 nerve root is compromised, and it would lead to weak plantar flexion. So what do you think, which branch of your sciatic nerve is going to be affected more in this case?
Posterior tibial.
That is tibial
Tibial.
nerve, right? So the ankle reflex is going to be lost. We know that we have an ankle reflex. You might have done that in your med school, right? If you're just striking the tendon of ankle, it's going to jerk inward, right? So whenever we have compromise or radiculopathy at the level of S1, tibial nerve is going to be affected. So it's difficult to stand on toes, because while standing on toes, we need to plantar flex the leg, right? So really important. You can see, okay, let me just show you the picture of this nerve, and it's going to become really easy. So you can see there are, okay, this is your sciatic nerve. It's a big nerve, it's having a lot of nerve roots, right? You can see, right? Okay, a lot of nerve roots, okay, which is going to make this big sciatic nerve. So whenever we have compromise of L5, what do you think? Which branch of sciatic nerve is going to be affected at L5?
Common parent.
Common
L5,
peroneal.
common peroneal. S1,
Tibial.
Tibial.
tibial. So you can see whenever you have radiculopathy at the level of S1, that's going to be tibial, and L5, that's going to be your common peroneal. Okay, is it clear? Okay.
Yes, sir.
Yes.
Radiculopathy syndrome. Okay, what is radiculopathy syndrome? We can have a third case here as well, right? What if we have radiculopathy or compression of L2, L3, and L4 nerve root? What would happen then? Yes.
Femur will affect.
Okay, so femoral nerve is going to be affected. L2, L3, and L4, right? So femoral nerve is going to be affected. If you guys remember, we discussed a patellar reflex. What was patellar reflex? If you're just, striking on the tendon of patella, you're going to kick forward. That was
Yeah.
basically looking for the activity of which
This
nerve?
like
Your
3,
femoral
4,
nerve.
L3, L4.
That
Like
is
3, 4, kick the door. Means
yes, 3, 4 kick the door. That's great to remember. Okay. So L2, L3, L4 is going to kick the door. Okay, let's just do it like that, right? So it means that whenever we have radiculopathy of L2, L3, L4 nerve root, femoral nerve is going to be affected. If you do not have proper femoral nerve function, what will happen? The patellar reflex is going to be lost, right? Okay. And what was the other function of femoral nerve? We discussed it's going to cause hip flexion. Did you guys remember the muscles which were leading to hip flexions?
Yeah, anterior compartment like quadriceps femoris and
Quadriceps.
medius latialis, laterales, and
I think the iliacus sartorius.
Yes, the
yeah, so iliacus also from the
Pectineus iliacus.
iliacus,
so
Sartorius and
so
pectineus.
right? Okay, so that's also going to be supplied by femoral nerve. So there would be, problem while, hip flexion and knee extension, right? Okay. So in order to look whether an individual is having radiculopathy, we are going to do something called a straight leg test, right? Or straight leg raise test, right? So as we are raising the leg, right? So again, what would happen? The spinal canal is going to become really thin, right? So with raising the leg straight upward, if we have pain, it means this individual is having radiculopathy. Is that clear? That's going to be called as Lasik sign, worsening pain. With raising the legs, the concept here is that again we are narrowing the spinal canal. If we are narrowing the spinal canal and individual is getting pain, it means he have radiculopathy. Is it clear? Hello.
yes, sir.
So now we
As
have
the
our
meaning, as the angle is small, more the severity is showing that. At 30 angle or 45, that means the severe stenosis. If it's go to 60 and 61, that's mild stenosis.
okay, yes. So at different angles, yes, that makes sense. Okay. Then we have our last topic remaining, that is hip. Okay. So it's really interesting. You have a lot of MCQs here as well, right? So we have hip joint. Which bones form your hip joints? The head of femur and acetabulum. So this is acetabulum, right? Okay. And it's basically which joint? It's an example of ball and socket joint, right? Hello?
Yes, sir.
Ball and
Humerus and this one.
joint can have a variety of range of movement. That is, we can have abduction there, we can have adduction, we can have flexion, we can have extension, we can have internal or external rotation as well, right? So the major flexors, what are the major flexors of your hip? As we discussed recently, ilias,
Ilias.
Ilias, rectus femoris,
tensor
tensor
fascia,
fasciae,
your tensor
pectineus and sartorius.
and pectineus and sartorius. Okay. What are the major extensors of your hip? That are the biggest muscle, which is your gluteus maximus, the hip muscle. Okay. What else? Hamstrings, as we discussed, the semimembranosus, semitendinosus, bicep femoris. They're going to lead to extension at the hip joint, right? What else? What are the major abductor of your hip joint? Really, really important. One of your viewers.
Medius.
Yes,
Medius and
minimus.
minimus.
Gluteus.
Minimus
Gluteus
and minimus.
medius and gluteus minimus, right? So this is your gluteus minimus, and this is your gluteus medius, which is going to lead to abduction at the hip joint. So you might guys might have seen this kind of exercise in gym, right? That is, we are abducting our, our thigh at the hip joint, and it's going to be done by these two muscles. That is gluteus minimus and gluteus medius. Okay. We have major adductor. What are the major adductor? We already know that. Adductor magnus, longus, brevis. Which nerve is going to supply them? We know that.
Obturator now.
Obturator.
Perfect, right? External rotation. Who causes okay, what is external rotation? You guys know the external rotation, right? If you are just moving it, like externally rotating, right? Which muscles are involved in external rotation? Gluteus maximus, obturator internus. So you have a canal which is known as obturator canal. Remember it, right? Okay, you have obturator canal. This is your obturator canal. So obturator internal muscle basically moves through that obturator canal, right? And it would lead to external rotation. Okay, we have gemellus superior and inferior muscles. You can see these are the gemellus superior and the gemellus inferior muscle. They are also your external rotators, right? And we have quadratus femoris. Quadratus femoris is this, rectangular kind of muscle, which also lead to external rotation, right? Okay, so these are your major external rotators. For internal rotation, which muscles do we have for that? Yes.
Gluteus medius, gluteus
Yeah.
minimus, and
Not have
tensor
a
fasciae.
primary muscle, right? But a group of muscles, once they act together, can lead to somehow internal rotation, right? So we do not have specific muscles in the hip joint for internal rotation. But some parts of your gluteus medius, minimus, tensor fasciae lata, adductor magnus and brevis, posterior head of adductor magnus, pectineus, some part of these muscles can help in internal rotation. So if you are using all of them combined, you can have a massive amount of internal rotation there, right? Okay, so let's discuss the nervous supply of different muscles. Superior gluteal nerve is going to supply which muscles? Yes, really simple, really important. The medius and minimus, right?
Yes, the superior provides gluteus minimus, medius, and the inferior supplies the maximum.
The
Gluteus.
inferior supplies the maximus, right?
Mm.
Okay, the inferior gluteal nerve would supply, your gluteus maximus, while your superior gluteal nerve basically supplies your medius and minimus, right? Okay, that's really important to know. Okay, so this is really important. So for example, whenever we are having any injection on the buttock, right? So we have different quadrants, The most suitable quadrant to have this injection is your outer and lateral quadrant, right? That is outer or upper lateral quadrant, right? So we have these four quadrants, 1, 2, 3, 4, right? So this is going to be very in order to have any kind of injection or intramuscular injections, right? But by any chance, if we have inexperienced, a physician or, nurse, and if he get, this injection into the upper medial quadrant, which nerve is going to be compromised then?
Superior gluteal nerve.
That is going to be
Superior gluteal nerve, which
superior gluteal nerve. Okay, superior gluteal nerve, right? And as we have, compromise of that superior gluteal nerve was basically supplying to which muscles, as we discussed now?
gluteus
Gluteus medius,
Minimus
minimus,
and medius.
and tensor fasciae lata. Yeah.
Yes, perfect. So as a result of the compromise of superior gluteal nerve, individual is going to be having something called Trendelenburg sign. What is Trendelenburg sign? Whenever the individual is walking, so his pelvis is going to tilt to one side. His pelvis is going to tilt on one side. That's basically called as Trendelenburg sign. You have a lot of MCQs in your U world. First of all, they are going to ask you which one is the safe quadrant. So the safe quadrant is upper lateral quadrant. If someone is having injection at the upper medial quadrant, which nerve is going to be compromised? This is your next U world MCQ. That's your superior gluteal
Nerve.
okay, which is going to compromise which muscles? Yes,
maximus, medius, and minimus.
medius and minimus, right? That are abductors, right? Okay, and as these muscle supply or the nervous supply is compromised, we're going to be having which sign? That is Trendelenburg sign. So whenever an individual is walking, so weight bearing leg cannot maintain the balance in that case. So we'll be having Trendelenburg sign, that is tilting of the pelvis. So here you can see that it's going to be, the weak abductors, we know that. Okay, the medius and minimus, also seen in some hip dislocations, right? So this is the how normal individual is, right? So the plane is really straight, but an individual with, compromise of superior gluteal nerve, he's going to be having tilting of this pelvis. You can see, right? Which is known as Trendelenburg positive sign. Okay. Hello.
Yes.
Okay. Then we have our inferior gluteal nerve, right? So inferior gluteal nerve basically supplies which muscle? Your muscle
Gluteus maximus.
which is your hip extensor, right? So individual with this case of, involvement of inferior gluteal nerve, he cannot, properly, stand from sitting position, because during standing we need extension, right? Extension cannot occur due to compromise of this nerve, which is going to lead to difficulty while standing. Avascular necrosis, really, really important, really high yield. You are going to see it in a lot of MCQs, right? What do we mean by avascular necrosis? Avascular, no vessels, no vessels, it means no blood supply, can lead to necrosis. That's so simple, right? So whenever the blood supply to the head of femur is compromised, we won't be having, the bone is going to become necrosed. It's going to become dead, right? So compromise of blood vessels, especially to the femoral head, can lead to necrosis, right? So we are going to be having growing pain, also in the thigh, the buttocks pain along with that. And weight bearing exercises cannot be done because we need to redistribute the weight to the lower legs. And as the head of your femur is necrosed, so you cannot, have that redistribution of weight. So here you can see what can lead to avascular necrosis. What are the causes? That's really important, right? It can be due to direct trauma. If you have direct trauma to the head of the femur, the vessels are, compromised there, we are going to have, avascular necrosis. What is the blood supply of the head of your femur? That's your medial circumflex femoral artery, right? Medial circumflex branches. Okay. Okay. What else? Steroid therapy, really important. You are going to be having an MCQ. We have an individual, he was having SLE, right? And they're going to give you a picture in which the head of your femur is going to be necrosed. What do you think? What do you think? What's the reason of necrosis here?
Steroids.
Steroids in SLE patient diseases.
Perfect. Sickle cell anemia. We discussed what happens in sickle cell disease. Remember that?
Vaso-occlusive crisis.
Vaso-occlusive crisis.
Why? Because your red blood cells were, sickling whenever there was stress, hypoxia, right? In a small blood vessel, this sickling is going to lead to avascular necrosis. Remember?
Yes.
And that avascular necrosis can still compromise the blood supply to the head of your femur, which can lead to sickle cell. Which can lead to Gaucher disease. We are going to discuss that. It's a lysosomal storage disease. We are going to discuss that in our biochemistry section in detail. It's also going to lead to avascular necrosis. Okay. Then we have SCFE. Okay, what is SCFE? That is slipped capital femoral epiphysis, right? So you can see, this is your epiphysis, right? And in the first set, they have just mentioned a really, interesting way of memorizing it. So you can just see it's going to be considered as a cone ice cream, right? Hello?
Yes.
Right? And sometimes this ice cream can just slip out from the cone, right? So you can see you have a fracture here, right? So this head, the ice cream from the cone is slipping out. So that's your SCFE, right? So it's slippage of overlying head end of the femur. So whenever the end of femur at this joint get fractured, it's slipped outward. It's same as that of ice cream falling off a cone. That's your SCFE. Okay. Hello.
Yes.
Okay. So as we know that we have our blood supply here as well, as we discussed, the circumflex is going to supply. So as the ice cream is falling off the cone, as the head of the femur is falling off this this head. Okay. So won't we be having vascular compromise? The vessels are also going to tear, right?
Yes.
And as that tear, what is going to we can have avascular necrosis again, right? To this head. Okay. Okay. So it's most commonly going to be seen. It's a hip disorder seen in adolescents. Really important, right? In young people who are just running, jumping, everything, right? They're young. So they can, when they are running and jumping and everything, so their ice cream can fall off the cone. That is your sticky, okay? Okay. Then we have another thing that is called as leg calf paresthesis disease, okay? It's commonly going to be seen in children, right? And what are we going to have in this condition? We are going to be having abnormal blood flow to femoral head. If we have abnormal blood flow to femoral head, what can happen? It can lead to avascular necrosis. And we have named this, thing a really complex. We have given a complex name, that is leg calf paresthesis disease, right? Okay. Okay. So whenever we have avascular necrosis in children, the head of the femur gets necrosed. That's going to be called as leg calf paresthesis. It's abnormal blood flow to the femoral head. It's going to present as hip pain and limping, right? So you can just see it here. No. Okay. So it's same as that of your. Hello. Okay. So with this, we have finished our anatomy portion, and let's discuss before discussing physiology. Today we are going to start our pathology from pathoma, right? So we are going to discuss a few, pathologies from pathoma, as I have listened that currently Dr. Hasnain is, doing pathology with you, right? So it's better to do pathology first, okay? The physiology is really small and simple. We are going to get started after our pathology, okay? As I discussed in the beginning, first of all, we are going to do the entire pathology from pathoma in detail. Then we are going to do it from first aid in our bootcamp session. Okay. So are you guys ready for your pathology?
Yes.
Pathology is really interesting, right? This pathology is really interesting. Okay. Since you guys know the anatomy, so pathology is going to be really easy for you guys as well. Okay. The first one which we are going to discuss is achondroplasia. Achondroplasia. What is chondro?
Cartilage.
Cartilage, right? Okay. So did you guys know that how does the mature bone forms? There are two ways for the formation of your mature bone. One is called as endochondral ossification, and other is known as intramembranous ossification, right? What is endochondral ossification? That's really simple. In the long bones, you're going to be having that growth plate, right? It's going to be, giving us a lot of cartilages, and those cartilages with time are going to become calcified, and it's going to turn into a mature bone. That's called as endochondral ossification. The chondrocyte, the cartilage is going to become hard with time by deposition of calcium and phosphate. This is going to give us mature, strong bone, right? That's endochondral. We have intramembranous ossification. That is your flayed bones. That is your bone of your skull, your sternum. They grow via intramembranous ossification. But in intramembranous ossification, they do not have like cartilage before turning into mature bone. There's going to be direct formation of bones at these intramembranous. So it's also going to lead to porous bone formation, like in the flayed bones of your sternum, of your skull, right? What happens in achondroplasia, it means achondros, some problem with the chondrocytes. So what do you think? Which ossification is going to be disturbed in this individual? Endochondral ossification or intramembranous? If you have problem with chondrocyte with cartilage.
Endochondral.
Endochondral. It means that the long bones are going to be affected. Am I right?
Yes.
Yes.
And the flat bones are not going to be affected because they have nothing to do with chondrocytes. Am I right? Hello?
Yes.
Okay, if the long bones are going to be affected, it means that individual is going to be having short extremities with normal head size. Can I say that?
Yes.
Yes.
So achondroplasia, A mean no, chondro mean cartilage, plasia, no formation or no development of or impaired cartilage proliferation or buildup, right? So it's impaired cartilage proliferation in growth plate, and it's the most common cause of dwarfism. When can we get achondroplasia? It's going to be due to mutation of FGFR3, right? It's an activating mutation. What do we mean by activating mutation? We are going to, okay, in some kind of mutation, we were deleting something, we were removing something, but in this kind of mutation, we are activating something, right? So increased activation of fibroblast growth factor is going to lead to problems with the development of your chondrocyte, leading to achondroplasia. Am I right? So overexpression of FGFR3 is going to inhibit the growth. Which growth? Endochondral bone formation, growth of your long bones. Am I right? So individual is going to have short extremity, normal size head and chest. Intramembranous is not affected. Does that make sense? Hello?
Yes.
Yes. So due to poor endochondral bone formation, intramembranous is not affected, right? Endochondral is basically characterized by formation of cartilage, which is then going to be calcified, we know, by the mechanism which occurs in the long bones. Intramembranous bone formation is characterized by bone formation without pre-existing cartilageous matrix, as we discussed. So this is not going to be affected. So we are going to be having, for example, a flared bones I discussed, your skull, rib cage, sternum, right? So the mental function is going to be normal lifespan, normal fertility, but the problem is dwarfism, not short bones. Is it clear? Hello.
Yes.
Yes, doctor.
Osteogenesis imperfecta. Imperfect formation of bone. Osteogenesis is your bone formation. What is imperfecta? Imperfect formation, of your bone. So I'm going to write imperfect. The I is big, right? Osteogenesis imperfecta. Its problem with 1. Collagen type 1. Bone is made up of BONE, B1, right? Type 1 collagen. Am I right? And imperfecta have that big I or 1. So in osteogenesis imperfecta, it is autosomal dominant defect in collagen type 1 formation. If collagen type 1 isn't formed properly, it means bones won't form properly. Am I right? Hello?
Yes.
Yes.
The bones are going to be really weak. Am I right?
Yes.
So
Yes.
we are going to be having this, multiple bone fracture. But type 1 collagen is not only present in bones. The sclera, the white portion is also, the type 1 collagen also, have information of your sclera as well. So if we have less type 1 collagen, the sclera is going to become really thin. And the choroid plexus, which we'll be discussing in eye, are going to be exposed. Choroid plexus have venous blood. Venous blood is basically blue in color. Am I right?
Yes.
Hello? So the thinning of the scleral collagen due to absence of type 1 collagen is going to expose the underlying choroidal plexus or veins, which is going to give you blue sclera. You have a UWorld MCQ, they are going to give you a picture of a child having blue eye. What's your diagnosis?
Osteogenesis imperfecta.
Osteogenesis imperfecta.
Imperfecta. Hearing loss as well. So in ear module, we are going to discuss, right? We have type 1 collagen there as well. We are going to discuss the cochlea in detail, right? So the cochlea basically is having a basement kind of membrane, right, made up of type 1 collagen. You have, otoliths as well, otoconia, which is going to produce sound. The entire thing is going to be discussed here, but here you should just keep one thing in mind. Type 1 collagen is also going to be, component of your ear as well. So if we lose type 1 collagen, in osteogenesis imperfecta, it's also going to lead to hearing problem as well. Is it clear? Hello?
Yes. Yes.
Perfect. Then we have osteopetrosis. What is petrosis? Petrosis stands for stone, big hard stone, right? Thick stone. Stone is petrosis, right? So in osteopetrosis, the bone is going to become very thick, but it's not going to be like stone. It's going to be like chalk. The chalk, we in our
Yes.
primary
Schools,
what we were
yes,
child, we just
Blackboard.
use a blackboard and a chalk, right? If you guys remember, right? White chalk. So although the white chalk was really thick, but it was really easier to break that, right? Hello?
Yes, sir.
Hello. So in osteopetrosis, what happens? The bone is going to be really thick, but it's going to be resembling, just as a chalk. Thick, but easy to break, right? Hello?
Yes.
Okay, perfect. So let me just erase it. Okay. So we know that we have osteoblast and osteoclast. We discussed it, multiple of time in different modules, osteoclast. What is the function of osteoblast? They make bone, right? And osteoclast, they destroy bone. They are macrophage, right?
Mhm.
Osteoclast make bone in alkaline environment, right? And osteoclast function in acidic environment. Am I right?
Yes, sir.
Okay. So if we have acidic environment, osteoclastic activity is going to be dominated. But for osteoclastic activity, we need osteoblast, right? The rank L receptor, rank ligand, remember?
Yes.
Okay. Okay. So
Yes.
keeping, okay. We discussed carbonic anhydrase 2. Did you guys remember carbonic anhydrase 2? What was the function in our renal section? It was just making an acid. Once CO2 combined with H2O in the presence of carbonic acid, it was just giving us H2CO3. H2CO3 was further giving us H plus and HCO3. Am I right? H plus is your acid. Am I right? Hello?
Yes.
Yes.
Yes,
So
sir.
can carbonic anhydrase 2 basically provide me acidic environment? And as we have acidic environment, then our osteoclast is going to function. Am I right?
Yes.
Hello? Okay. If we have, somehow loss of this carbonic anhydrase 2, it means we cannot make an acidic environment. Am I right?
Yes.
If we do not make acidic environment, it means the osteoclast cannot function, right? So osteoblasts are going to function more because still we have alkaline environment, because acid-base disturbance are going to be seen. Less acid mean, on the other hand, the balance is going to shift towards more HCO3, right? That is more alkaline environment. So in osteopetrosis, we have multiple genetic variants, which is going to lead to dysfunctioning carbonic anhydrase 2. No carbonic anhydrase 2 cannot make acidic environment. Osteoclast cannot function properly. If osteoclast cannot function properly, osteoblasts are going to function more. But osteoclast basically lay down bone, but it would just lay down bone in the really quick manner, right? Because we are directly activating a lot of osteoblastic activity. So as quick making or quick bone formation is going to lead to a bone formation which would be thick, but it would not be having that strong or strengthened integrity of a real bone, right? It can fracture easily just as a chalk. So it would lead to osteopetrosis. Am I right?
Yes.
Okay. What are going to be the clinical features? Bone fractures. Why? Still the bone is thick, but it's just as a chalk. You can easily break it, right? Anemia, thrombocytopenia, leukopenia. Why? Because the bone is going to become so thick that the medullary portion where your bone marrows, your hematopoietic stem cell lies, it's also going to be replaced by that thick bone. And as we replace the bone marrow, can we make red blood cells?
No, we can't.
No.
Please, yeah.
Can we make thrombocytes, platelets from the myeloid lineage as we discussed in detail? No. Okay. Okay. So we know that in the skull, different cranial nerves, move out from the skull in certain foramens, right? So we'll be discussing that. And you have a big foramen called foramen magnum as well, where your brain stem is going to enter into your skull. Am I right?
Yes.
So if we have osteopetrosis, a lot of bone formation, so won't that foramen become thin? Won't it compromise
Thick.
the nerve which
Blood
are
flow.
moving out to the foramens? Yes. So we are
Yes.
going
It
to
will
having
become narrow.
impairment, vision impairment, as you know that your optic nerve is going to move out to a foramen, which we'll be discussing in detail in our neurology section, which is going to come after this, right? Hydrocephalus, as we are, as the bone is thickening, the lumen size of your foramen magnum is going to decrease. And as it decreases, the CSF can build up in the brain, which is going to lead to hydrocephalus. Because we'll be discussing in neurology that CSF is formed in the lateral ventricles. It would move to the third ventricle, to the fourth ventricle. Fourth ventricle is basically present, half it's present in the pons, half in the medulla, right? And the pons and medulla are going to, then give your spinal cord or the spinal canal, which is going to move through the foramen magnum. So if I'm just compressing the foramen magnum, it's going to lead to accumulation of CSF back in the brain, which is going to lead to hydrocephalus. Is it clear? Hello?
Yes, sir. Sir, I have some confusion. Please, if you clear. Osteoporosis, in the pathomized, the one line is written that
Multiple genetic variants exist. Carbonic anhydrase mutation leads to loss of the acidic microenvironment required for the bone resorption. That means for the bone resorption, we need acidic environment.
Yes.
Yeah, but the last line is that lack of carbonic anhydrate result in decreased tubular reabsorption of the bicarb, leading to metabolic acidosis.
Yes.
That means body is already if is in this condition of metabolic acidosis, and there should be not compromise the bone reabsorption. It's the two different thing might be,
Okay. Okay. Did you okay? Okay, I'm going to come to renal tubular acidosis, but till here, is it clear that acidic environment is important for osteoclast function?
Yes, we know that osteoclasts they excrete hydrogen ions locally that help him to bone reabsorption. And but the confusion is between these two lines. If the mutation in the carbonic anhydrates, that means already body in acidic condition.
Okay, okay. Let me just tell you, the body isn't in acid, right? Remember one thing, we discussed in our renal section. How do we reabsorb HCO3? Do you guys remember that?
Yes. PC,
What was
PCD.
In the proximal tubules, there is
proximal convoluted tubule?
convoluted tubules. Yes.
Yeah. Okay, let me just write down the entire pathway, then it's going to be really clear, right? Okay. We discussed that, for example, if this is your lumen, right, and you have HCO3 here, right? So inside your cells, what would happen? You're going to be having carbonic anhydrase 2 activity. You're going to be having H plus in the end and HCO3, right? This H plus is going to move out into the lumen, right? It's going to catch this HCO3. We're going to be having H2CO3 and carbonic
Carbonic
anhydrase.
acid, yes.
It's then going to convert it into CO2 plus H2.
Water plus CO2.
Because carbonic anhydrase can just function in both of the direction. They can make SCO3, and from H2CO3 they can again make your CO2 and H2 as well, right?
Yes.
Okay, the H2O, the carbon dioxide was moving back. Again it was combining here with your with your water. It was again giving you H plus and HCO3. So as we are moving one H plus out, one HCO3 is reabsorbed. Did you guys remember?
Yes.
So the goal is that whenever I'm just moving out one H plus out into the lumen, it's going to catch the HCO3 and it's going to reabsorb the HCO3 back into the body. Am I right?
Yes.
Okay. So if we do not have carbonic anhydrase, can we catch the HCO3?
No.
Okay. Can we reabsorb HCO3?
No.
If we cannot reabsorb HCO3, would it lead to metabolic acidosis?
Yes.
So carbonic anhydrase 2 mutation can lead to metabolic acidosis. We do not have metabolic acidosis. It can leading to metabolic acidosis. Is it clear?
Yes, sir.
Okay. So we do not have metabolic acidosis. It would lead to metabolic acidosis. Okay. Hello?
Okay, sir.
Okay. Perfect. And another thing which we should just focus here, you can see that the carbonic anhydrase 2 would lead to loss of acidic microenvironment. It means that the carbonic anhydrase is going to make our, surrounding your osteoclast, you need that microenvironment to be acidic. It has nothing to do with the macro environment, metabolic acidosis, right? So carbonic anhydrase in
Exactly.
in the periphery of your osteoclast is going to make your acidic environment, right? So it means that the function of osteoclast, depend on that microacidic environment, not on the macroacidic environment, right? Hello?
Yes, understand.
Does it make sense?
Yes, sir, understood. Thank you.
Perfect. So what is going to be the treatment? The problem here is with osteoclast, right? So just do a bone marrow transplant. Why? Because we know that osteoclasts are your bone marrow macrophages. Macrophages comes from your myeloid lineage, from your bone marrow. So just give a bone marrow transplant, just give them a proper functioning osteoclast. This pathology is going to be reversed. Everything is going to be fine then. Is that clear?
Yes.
Yes,
Perfect, right? So this was all about osteopetrosis. So the time is finished for today's session. Okay, we are going to cover these pathologies tomorrow. And as I mentioned that after pathoma, we are going to refer towards our, our first aid. And that was all. Hope so you guys enjoyed the session. Thank you so much. Thank you and see you tomorrow. Okay,
Okay, thank you.
thank you.